Good morning, everyone, and Happy New Year. I want to welcome everyone to our Nurture 2023 Nurture Me conference that was rescheduled from last October. I'm glad that we were able to reconvene and have this scheduled today. For those who do not know me, I'm Dr. Puthiery, Director of Maine Center for Disease Control and Prevention, and I too am very pleased to be here. Even more pleased to see that there are so many dedicated partners and folks on this call, beyond 200. That's really exciting to see that there are so many people here today in support of Maine children and families. So today's summit brings together stakeholders, professionals, and community members who share a common interest of supporting the well-being of children and families throughout their lives here in Maine. Today, we will highlight several areas where we are succeeding and celebrate those wins together. We will also identify other areas where we can use past experience, collective efforts, and data to help pave the way forward for healthier families and communities here in Maine. For those of you that I have not yet had the opportunity to meet, I want to introduce myself a little bit more. I took on the role of Maine CDC Director in August of 2023. And before coming here, I earned my medical degree right here in Maine at the New England College of Osteopathic Medicine, UNE. And I am board certified in internal medicine. I complete and then followed that with the completion of a fellowship focused on medical epidemiology with the US CDC. I was then honored to return here after serving as the public health director for the last 5-ish years for the Indian Health Services and Chinle Service Unit on the Navajo Nation. Since my arrival here at Maine CDC, I've spent a ton of time getting to know the folks here and just the broad and varied work completed by my colleagues here, also amongst our partners here on this call. I will bring out the one specific division. The Division of Disease Prevention is just one of our divisions, but it has a heavy presence here today. This division helps to support public health through the work in critical areas of perinatal health, women, infants, and children, chronic disease prevention and control, oral health, and substance use prevention. 2 of the division's programs, the Maternal and Child Health Program and the Tobacco and Substance Use Prevention and Control Team, are the co-sponsors of today's program. And I am thankful and grateful for the efforts of the staff, both in their day-to-day jobs, but also for all they have done to bring us back together here today. Next, I want to spend some time just highlighting our Maine CDC approach and also shine a light on 3 programs that exemplify our public health work: Maternal Child Health, WIC, and the Tobacco and Substance Use Prevention and Control Program. These programs provide support and services across the lifespan with an emphasis on critical developmental periods for children, adolescents, and families. They also model a shared risk and protective factors framework. For those who are not familiar with this, what is that? We understand that poor physical and mental health outcomes have shared root causes. As public health, we know that. They also have shared risk and protective factors that impacts one's trajectory over the life course at the individual, family, and community levels. Examples of the shared risks include ACEs, adverse childhood experiences, such as individual exposures to violence, conflict, and substance use and abuse within the home. Communities where families frequently experience food insecurity. Equally important are examples of shared protective factors that need to be enhanced. These include, and you'll hear about this, strong nurturing family engagement, positive connectedness to families or adults outside the family. Our work focus on reducing those shared risk factors, as well as enhancing those protective factors to create a more resilient, protective environment. So let's go ahead and highlight those notable wins. What are they? For Maternal and Child Health Program. This program manages and guides the work of many public health initiatives, all of which center around family engagement and health equity. The team's work is critical to the health and well-being of children and families from the very first hours of a child's life. For example, the program works to ensure that newborn health screenings are completed on every baby born in Maine. That's what I said, every baby born in Maine. And that each child receives needed follow-up based on the results of these screenings. Our Maternal Child Health Program also provides safe places for babies to sleep at no cost, helps ensure quality and accessible clinical planning, family planning services, and provides home visiting services to educate caregivers about a child's development. The success of the work of this team is evident in our data, because we wouldn't be public health if we didn't talk about data, right? Maine leads the nation in the percentage of infants that are placed in the back-to-sleep position, 91%. And Maine also excels in the percentage of pregnant people who begin getting perinatal care in the first trimester at 90%. That is quite impressive. Our supplemental nutrition program for women, infants, and children, or as I mentioned earlier, WIC, supports Maine's families with free nutrition advice and resources, including breastfeeding and chest feeding information and support, and has also seen great success this year. We've improved participant access with the ability to hold remote appointments. And as a result, we've seen the highest WIC participation in 3 years, with a current roster of 18,200 participants. That is impressive. And the program continues to innovate and adapt to meet changing needs. This is what we do as public health. We know that the environment and the challenges change, and we have to adapt. For example, WIC is partnering with community health workers to support New Mainers by offering individualized shopping trips to access their WIC prescribed food. And another highlight from WIC, and this is a win-win example, is the continuation of the Farmers Market Nutrition Program. This program saw record level redemption this year with over $100,000 for Maine-grown fruits and veggies going directly to Maine's farmers, while also providing WIC recipients with quality local nutrition. And the third program I want to shine a light on is the Tobacco and Substance Use Prevention Control Team, who works hard to support pregnant people, new parents, children, teens, by providing resources on quitting and education for families. The program has run many successful public awareness campaigns and has worked collaboratively across the different sectors here in the state government, but also across the communities. And the data shows that, and they're making good efforts. For example, we've seen social norms and changing attitudes shift, so much so that vaping has gone down amongst teens, significantly gone down amongst teens. So I want to take this moment to thank all of those dedicated employees at the Maternal Child Health and team, with the Tobacco and Substance Use Prevention Control Team and the WIC team, and really the many other critical programs in the Division of Disease Prevention, and to many of you at this summit today, because it is a collective effort. So thank you. We know that Maine kids are getting the strongest start as possible in life. While all these wins are worth celebrating, the data does tell us that we, of course, face ongoing and new emerging challenges as a public health team, a collective public health team. For example, in 2020, 10% of pregnant people reportedly smoked cigarettes. That's 1 in 10. And we still have plenty of room to improve in lowering rates of smoking in children's homes. Also, it would be hard not to acknowledge the behavioral and mental health challenges faced by children, adolescents, and families. In 2021, 20 out of 1,000 infants were impacted by neonatal abstinence syndrome. 20 out of 1,000 infants. 62.3% of children, adolescents need mental health treatment, but currently do not get it. We recognize that we need to improve access to mental care, mental health treatment for children, adolescents, and postpartum people. We recognize that. But equally important, we also need to continue to work on enhancing those protective factors that I mentioned earlier, while reducing known risk factors that promotes a resilient environment, nurturing the mental and physical well-being of children and families here in Maine. I know that these stats are hard to hear, and sometimes those challenges can seem really difficult to tackle. But I'm here to tell you that I am ready, and that the Maine CDC is already hard at work tackling this. And I'll give you 2 more examples because I can't, just to show how proactive and how positive the trajectory is, and what we're willing to put into all of this, because we care. One is that we are committed to enhancing our capacity to diagnose fetal alcohol spectrum disorders, FASD. For those who may not know, this is the leading preventable birth defect, and currently even more common than Down syndrome and autism. You'll hear more about some of the progress later today. The other effort that's happening is at the Office of Maine Care Services Maine Moms Program. This is a collaborative effort, and this program aims to improve the care for pregnant and postpartum people with opioid use disorder and infants. The model provides wraparound services that integrates healthcare from conception through 1 year postpartum with substance use treatment and supports, including peer recovery coaches. Maine Mom served nearly 180 members from July 2021 to July 2023. And there are plans of expansions into 2024, which will allow the model to spread to new providers and sites across the state. These efforts, along with many others that will be highlighted today, combined with the expertise and resources of all the partners present here, will no doubt continue to improve health outcomes, access, and equity in our state. I'm excited to lead Maine CDC. This area specifically is a priority of ours and of mine, and I'm excited to partner with you all in the continuing collective efforts to ensure that Maine is the way life should be for all children and families. All right, guys. I am even more excited to introduce our keynote speaker today. She is a perinatal and maternal child health nurse with more than 25 years of experience, training, and expertise in trauma-informed care among diverse healthcare settings. She is passionate about strength-based approaches and a proponent of compassionate communication as a cornerstone of her work. She supports parents-to-be, and birth professionals in implementing innovative practices for improving and sustaining better health outcomes in the field, workplace, and at home. I want to introduce Farrah Sheehan, who joins us today with a master's in science in nursing leadership, immense knowledge as a registered nurse, as well as a certification as a birthing from within mentor and a trained birth story listener. In addition to all of that, she is an international board certified lactation consultant who has an expansive career, wealth of experience, and unwavering advocacy that demonstrates her exceptional dedication in the field of perinatal care. Her steadfast promotion of compassionate healthcare with individuals, families, and professionals really shines through in every aspect of her practice. Today, Farrah will be sharing some important messages about how to improve family engagement and the work that we do. Please take a moment to join me in a heartfelt welcome to our keynote speaker, Farrah, and welcome, Farrah.
Thank you so much, Dr. Va. I'm excited and nervous and just really honored actually to be here and serve Maine in this way. Let me start my share here. I'm also, full disclosure, trying to, improve, as we all are all the time in our online presentations. So I'm using Prezi live for the first time. Usually I do this recorded. And so just bear with me if I have any little glitches here. Dr. Va, you just really described so much of the success that Maine has had in patient engagement, actually, and family engagement, and then also some of the ways that, we can all be doing a little bit better. So I'd like us to just get started with setting our intentions here today. And what is it that we really want to be, focused on as we think about engagement with the people that we're serving? I also want to take a moment to name that, this beautiful land of Maine originally belonged to the Wabanaki people, and just to honor this place and space. And also to share that, as we're talking about pregnancy and birth, just recognizing that pregnant people have a variety of gender identities. And when we talk about research, when we talk about families, we will do our best to use, to encompass all of that. And also note that a lot of the language that we use is very gender specific, especially when it comes to research. Also, I want to just name some assumptions today that I'm moving from, which is essentially that we come to this work with history, with culture, with all of our own assumptions and beliefs. And some of mine are that I believe, and I know you all do too, that people deserve to be cared for safely, with compassion. And also just to name that when we're talking about the perinatal period and maternal child health, that these are rites of passages. These are really sacred events, I believe, that people are moving through. And sometimes in our healthcare world, we forget that. We end up just kind of going through our checklists, and we forget that this is really a once in a lifetime sacred moment sometimes for folks. And so just trying to ground us in that, remember that these are really important, essential, beautiful times of people's lives. When it comes to engagement and doing our work and really committing ourselves to helping families to be engaged, I was reflecting on one of my mentors, David White, an amazing poet and philosopher. And he says, when we are looking at achieving maturity in our work, which I think is what it takes to be able to really help families engage and to have the energy that we need to do that, he says, this is the result of application, dedication, an indispensable sense of humor, which we all need, and above all, a never-ending courageous conversation with ourselves, with those with whom we work and those whom we serve. And today we'll explore all of those elements, actually, like what are the people that we serve saying about, how we're engaging with them and what do they need, and then hopefully have a few minutes to share with our colleagues. So we want to explore the reasons for lack of engagement in the perinatal period, some strategies and approaches to improve engagement in perinatal and maternal child health. And firstly, we're going to start with you all sharing your why, and just identifying what your intention, vision, wish, dream for all families are in your work, because that helps us with family engagement. That helps us to want to do that. So you can either copy the link that I believe should be in the chat. Lorena, if you can put that in the chat for folks, this link here. You can also go ahead and grab this QR code using your phone if you're tech enough to do that. So I'll give you a moment to do that, and then you should be able to start putting in some responses there. And I am going to move us into, hopefully everybody's had a chance to grab that. And I'm going to let us see the results. Hopefully this will work for us so we can see what's happening here with our poll. Let me share again. And our word cloud should be populating okay. Let me know, Lorena, if you can't see that on the screen. So our intention, vision, dream, wish for all moms, babies, families, support is obviously a huge thing that's standing out, which is directly linked to engagement. People can get the support they need when they're well engaged. Health, equity, community together, safety, love, empowerment, happiness. Beautiful. Thank you so much for sharing that. And you can continue to do that. And I will probably share that again at the end. And there's that QR code again, if anybody needs it. And again, the link will be in the chat. So just a way for us to collectively see, what our intentions are. I've done this activity before, and these are some of the things that are identified and what our intentions are. We want people to be safe, well, and healthy, have personal freedom to make good healthcare choices for themselves and their families. And, love was mentioned on that screen, right? So joyous, positive, loving experiences to reach their full potential. That's what we all want. I do want to name, as we move into talking about engagement, just to separate out access from engagement. Sometimes access and engagement are words that are interchanged in healthcare, but access is really that part of being able to come in and get the care that you need with just the basics. You have insurance, you have transportation, there's no language barriers. Everybody should have access to healthcare. We definitely have barriers with that. Today, we're not addressing that so much. We're really addressing the engagement piece. We're going to assume that access is already taken care of. We must have access to have engagement. And those are definitely things that I know we're all working on as well. So some of the foundations for engagement. So Pema Chodron, who's a Buddhist nun, says that compassion, which I believe is a foundation for engagement, is not a relationship between the healer and the wounded. It's a relationship between equals. Only when we know our own darkness well can we be present with the darkness of others. Compassion becomes real when we recognize our shared humanity. So when I hear from families that they are wanting to engage in healthcare, even if they're really struggling or feeling afraid, it's because someone's been compassionate with them, right? It's when we are able to recognize our shared humanity and someone knows that they're not alone. This definition of engagement from Higgins research I found to be really valuable. It's the desire and capability to actively choose to participate in care in a way uniquely appropriate to the individual in cooperation with a healthcare provider or institution for the purposes of maximizing outcomes or improving experiences of care. So I think that's a really nice summary of what we're talking about when we say engagement. And when do people engage with healthcare? Sometimes it's because they have a really positive relationship with their provider or the place. Maybe they even have generational relationship with a particular hospital. For generations, babies were born there, for example, or they believe it's really valuable for themselves or their family. But also we can have negative influencers. Sometimes people engage in healthcare because they have to, because they're forced to, they're pressured to, their culture tells them to, their parents tell them to. They're involved with child protective services and they have to do something and they might not necessarily want to. So that's not ideal engagement, but sometimes it can be the first step to getting people to actually come in for care. How does engagement look for us? So if I'm a healthcare professional within a clinic or a hospital, what does it look like when people are engaged? Well, they're coming in for their appointments. They're seeking care appropriately. They are viewing me as a trusted source of information, or if they're not totally trusting, they're willing to ask me questions, maybe be really honest with me about their healthcare choices. For example, if a family doesn't want to follow the full recommendation of the vaccine schedule, they might say, well, I don't really want to do this one, and here's why. I'm going to wait on it until this time. That would be engagement. It's not necessarily that they're always following my advice, but they're going to, be able to communicate with me and share with me and feel safe in doing that. They follow through with their own healthcare plans. They might have their family be a part of their care, and they're open and honest about their healthcare status. They're disclosing things that are important for their care. So that's really, in the best case scenario of engagement, what we're talking about, right? So I loved this study is really a great read, Marzipan and colleagues. It's really recent, and they explored what the consequences of patient engagement were. So they definitely found obviously improvements in health outcomes. So for example, long-term recovery, better diabetic management, compliance with, post-op, all sorts of things. Patient compliance, fits into that, obviously, being able to follow through with what the recommendations are of the healthcare provider. I thought number 3 was really interesting and I loved it. And it's self-efficacy. It's really the belief that that as a human being, they are doing their best and they believe in themselves. And it's kind of an increase in confidence because they're engaged in care. So this is especially important when we're talking about parenting and the maternal child health period, time that we're all caring for people in. And the other one that they found was return on investment. And I think a great example of this is the Eat, Sleep, Console model that has been implemented in most of Maine's hospitals. And what that showed us is that when families are engaged in care, especially for their newborn that might be experiencing neonatal abstinence or withdrawal syndrome, when they're coming in and they're taking care of their baby and they're holding and they're loving their baby, and maybe breastfeeding, and they're rooming in, we know that we have, shorter length of stay. We have babies who aren't needing medication treatment. They're not needing that as much or less or not at all. And so that's decreasing our healthcare costs, right? It's a return on investment. So those were 4, I think, really essential things that are important with engagement that this study identified. And then they also shared that patient engagement can improve both treatment outcomes and consequently patient satisfaction. So then it actually filters into or flows into that, patient experience, which is important as well, and productivity of the provider. So patient engagement isn't just about health outcomes, but it's really the whole, it encompasses all of the care that we're providing, including our own experience. So what are some of the barriers and inhibitors? Similar to this mountain top, this peak here, I think that sometimes we see things as being barriers, but once we get there and we can really like stand and recognize it, we can see the beauty of it. And there's an opportunity for reflection. There's an opportunity for feeling really good about having achieved something that was really hard. So I want us to explore that next. I also just wanted to mention too, while I'm thinking of it, to please go ahead and put any questions, thoughts, comments into the Q&A while we're chatting. I'm happy to look at those at the end, but do put them in as we're going if you like. So what inhibits patient engagement? Take a moment to consider this in your practice setting. Just make a mental note or maybe even write down an example just to kind of, really think about it as we're moving through this. What prevents people from engaging in care? Have you recently had a family that you're worried about, that you really wish they were coming in? They're not showing up for care, whatever it is. What do you think is preventing them from that? Aside from the access piece, like transportation, health insurance, things like that, more of the engagement, like why aren't they, if they have all their needs met, why aren't they coming in? What's preventing them from that? Some things that we could consider are historical and social constructs that prevent patient engagement, right? So it might be socioeconomics, which of course has to do with access as well. It might be systemic racism. It might be stigmatization and criminalization if they're using substances or for some other reason. It might be family history or generational mistrust of the healthcare system. If someone had a bad experience in a family, like a grandparent or a parent, and that story gets told, that narrative gets passed down, then their children might have a hard time engaging with the same system or with healthcare in general. So these narratives can perpetuate difficulty with engagement, even if access is there. I really liked American Association on Health and Disabilities, Social Determinants of Health, to help us understand engagement because it's really comprehensive. So this especially names like healthcare discrimination, which people definitely deal with, stress, social supports. So, again, some of this access is woven into it, but some of it is even when access is there, the engagement piece is lacking. So it's really important to name, especially in states where we have a higher Indigenous population like Maine, that sometimes lack of engagement can be for fear or for family history of risk when engaging in the healthcare system. So when people engage in the healthcare system, if they're struggling with caring for themselves and their families, or they're at risk for abuse and neglect, or they're struggling with poverty, substance use, and they're of a population that has a history of increased risk in entry into the foster care system or removal of their children from their home and their care, then they're going to have, it makes sense that they'll have fear about engaging in a system that might end up putting them at risk for that loss of caring for their children. And so it's important for us to recognize that there is a discrepancy, that there is inequity in how we care for and address challenges of childcare within families among different populations. And we can see here, this isn't specific to Maine, this is US, but Indigenous families and Black families have a higher rate of children entering the foster care system than their white counterparts. So how does that affect someone's engagement in healthcare? Does it? Similarly, when it comes to criminalization of substance use, on average, a Black person is 3.5 times more likely to be arrested for marijuana possession than a white person. And in some states, it was found to be 5 times higher. This is from the ACLU. And so again, similarly, if someone is sharing their history or current, substance use, and they're of a population where they're at greater risk for consequences of that, that may prevent them from getting the care that they need. So these are some things that we need to really be mindful of when it comes to wanting to improve engagement. So I'm going to try and share a poll here. Let's see if I can do that. Now I don't see it, Lorena. There's more. Bear with me one moment. Polls and quizzes. I think there might be, here we go. So what do you think is, hopefully you guys can see this. What do you think is the biggest barrier to patient engagement among families affected by substance use? So just like in 1 or 2 words, you'll just go ahead and name that. Just give it another minute or so. There's so many of you here, it's coming in fast and furious. And I'm really focusing today, it's worth mentioning on the populations of people, obviously, that we know have, the biggest barriers with engagement, right? Like we heard at the outset how well Maine is doing with so many things in WIC and, in helping youth do better with vaping. I mean, so obviously how you guys and how Maine is managing patient engagement is excellent, right? But we still have populations that we're struggling with. And we know that because of maternal morbidity and mortality and families that are struggling with substance use. So let's see, I'm going to end that poll and share. And what do we have? I don't see the answers. Do you see them, Lorena? Let's see. Share results. I don't know if you can help me with that, Lorena. I'm not seeing.
Did you hit shared results? I'm not.
Yeah, I hit share results and then it just says stop sharing. And then I hit share results again. So we'll come back to that. Hopefully we can get our results. I don't know if maybe there's just so many, but yeah, when I hit share results, it just tells me to stop sharing. Maybe I have to stop sharing my screen in order to share results. Share results.
I'm not sure. Maybe stop sharing and see if let's see.
It's okay. So I'm going to go back to.
I'm not sure why.
I'm assuming that most of you know that it's fear. And hopefully we'll find those results momentarily. But fear is definitely the biggest barrier for families that are struggling with substance use, right? Like we shared in the slide before, for Black and Indigenous families have a higher incidence of having children enter the foster care system. Obviously it's higher as well for families that are struggling with substance use. And there's stories around that people share, and there's fear. And so the stigma and fear from this study on Wolfson, which again was relatively recent as well, stigma and fear of these systems prevented women from seeking services that they needed. And in this study, it names that accessing services could have benefited from their pregnancy, but I'm going to go a step farther and say that accessing services could actually save their life, right? I'm not sure in Maine where you're at with maternal morbidity and mortality and what the primary factor is there. In New Hampshire, I sit on the morbidity and mortality review committee, or I have in the past years. And what we've identified is that substance use and mental health are the primary reasons for maternal mortality in New Hampshire. And there's always an engagement and access issue, when we go back and look at the trajectory of what happened in each case. And so not getting the care that they needed is the thing, is one of the primary issues that led to death. So it's not just about having better healthcare, it's about survival. And fear of child removal hindered women's ability to seek support and assistance. And it forces them to conceal their use, which then perpetuates isolation, domestic violence, and further trauma. It also, in some cases, after removal of a child from the home is when, the overdose or suicide occurred. So sometimes there's actually a direct link between the trauma of losing a child and the death. Stigmatization and criminalization of substance use affects patient engagement, right? So we also want to look at the social aspects, the historical aspects, and the medical aspects of what's happening here. So in our social, sort of conditioning, right, over a little bit over 100 years ago is when we really started with criminalization of substances in the United States, and then eventually, the war on drugs. And really, there's a message there that people who use drugs are bad, are innately bad humans, or innately bad parents. Now, you and I might not actually believe that to be true, but there is a social messaging around that, right? And that does infiltrate into the work that we do and into people's own psyches. Once involved in the child protective system, discriminatory practices, including classism, make reunification impossible. One example I have of that is I was working with a family who didn't have enough bedrooms. So once they had child protective services involved, because they didn't have enough money to have an apartment that had enough bedrooms, they weren't able to reunify with their children, even though they were doing everything else they were supposed to do to be safe. And so we have these discriminatory practices that prevent people from, if their children are removed, even getting them back. And families know that. And so that perpetuates the fear. Also, we have to recognize that criminalization of substances leads to family separation, loss of income, housing, family instability, and then that just perpetuates the neglect and possible abuse that is happening in a family. So every time we are criminalizing, we are putting families at further risk. And then we have the kind of historical and medical aspects as well that, for example, cannabis is classified as a Schedule I drug, whereas fentanyl and oxycodone, which you're probably all aware of, are classified as Schedule II drugs, which essentially means, that cannabis is classified as more dangerous. We all know that what's killing people is fentanyl and not cannabis. Doesn't mean that cannabis isn't a substance that we need to be concerned about. We certainly do. But when we have the mix and the soup of all of this messaging that isn't exactly equitable, there's fear, right, for people to be able to come in and engage. And the intersection between racism and criminal justice in our drug laws and policies and practices really make it so that certain populations of people, including Black people, are incarcerated at a higher rate than white people for the same issues. And then with medical conditioning, so, do we have to report to Child Protective Services? What do we report for? There's state laws, there's federal laws, there's institutional practices. And I would say also that there's fear of loss of license or retribution, which actually there aren't any examples of that I've ever been able to find in the literature or news or anything. But I think that we all sometimes have fear that something bad's going to happen to us when that's probably not, actually reality. And the people that we're caring for have this other really huge fear. So these fears sort of are kind of coming together to perpetuate sort of these, habitual responses that we have. So I'm going to, make a big statement here that substance use and abuse doesn't actually always equal child abuse and neglect. And there's definitely, we have to look at our CARA and our CAPTA laws, but I'm going to just tease out some of this a little bit and give you a couple of examples of why this might not always be the case. So one of the things that I want us to think about, even if you do believe that substance abuse does always equal child abuse and neglect, because you may, and some people do believe that, is that when you are considering reporting a birthing parent who uses substances and you're thinking about engagement and care from that lens, like, what is the benefit versus the risk of that report and possible inquiry? So it doesn't mean that we don't do it, or if there's a law that we have to do it, but how do we really think about it in a way that is helping us to also assure that we're keeping people as safe as we can and helping them to engage? So what's the effect on the trust of the healthcare system? How are we navigating that? Are we encouraging people? Are we telling people, hey, come be with me, I need to make this report, but it's about you and your family, and I want you to be a part of this. Like, you have to be. This is, what we do here. How is it going to affect their future engagement, the story they tell their children, and their engagement in healthcare, right? Like, thinking really down the line. Re-traumatization from past experiences with being involved. How does it affect their physiologic state, the stress that they have on themselves and on their infant? Does the risk of infant abuse or neglect warrant the above stressors if there actually isn't anything happening except for maybe that a parent has a history or that they're in treatment? If they're doing everything really well and there's no sign of abuse or neglect, how do we weigh out the risk versus benefit of a report? What about for a mom who's using THC regularly, or cigarettes or alcohol, or putting her baby at risk in any way with any substance? And what are other ways to help a family with substance use if there is no evidence of abuse or neglect, to really help them to stay engaged and to be safe at discharge? So these are just some things that I think we should be thinking about. And oftentimes we respond and act automatically and habitually because of our training or because of assumptions. And we're not always really stopping to think about all these pieces. In New Hampshire, actually, we really took this issue on with we had a perinatal substance exposure task force. Sorry, I lost my words there for a moment. And for many years in New Hampshire, and now it's a collaborative because it's not within our state funding anymore. But essentially, through a lot of research with the Institute for Health Policy and Practice at UNH, we came to a place of really teasing out the law and health equity and just figuring out how to approach this as best as possible. Now, all hospitals in New Hampshire really are still doing things relatively differently. But the essential findings were that the fact that an infant is born with withdrawal symptoms or prenatal exposure to drugs and alcohol, I'm reading from this first piece here, more broadly, does not itself constitute abuse or neglect of an infant, nor require a mandatory report. Furthermore, the fact that a provider develops a plan of safe care with a mother does not necessarily mean the provider has a reason to suspect child abuse or neglect. So essentially, hopefully you all know the plan of safe care. And that's really what we're doing in New Hampshire to help people to stay engaged, is use that plan of safe care. And if there's a risk of or a concern of abuse or neglect, to go ahead and make that report and send the plan of safe care, of course, to, we call it Department of Children, Youth, and Families. I believe you call it Child Protective Services. So some states are really trying to look at health equity, engagement, risk, and the law, and see, like, what can we do for families? Again, I'm not saying that in every place we don't make reports. Sometimes we do. But how can we really be aware of the engagement?
I was holding my daughter.
I'm just going to share this story with you.
Born while in the hospital, and I had fallen asleep with her due to pure exhaustion. She was in my arms, and I dropped her on the tile floor, and she had a fractured skull and 2 brain bleeds. So on top of the guilt I had already had and being under the microscope of DCYF, I was told by the team that they would have to also report the fact that I dropped my daughter due to exhaustion. And my response was, then you need to call DCYF on the entire maternity ward, because all of these mothers, including myself, are exhausted. Why do you even have to mention that in the report? I felt judged, I felt helpless, and I felt like I couldn't bond with my daughter. I felt like she might die because of her brain injury, or DCYF might take her, knowing that I have no supports at home and knowing that I'm in the drug-assisted program to help stay clean. And I felt like my daughter was going to be taken away from me. I feel like everything could have been handled a lot better with more compassion especially towards mothers in recovery.
So that was a patient who I have permission to share her story that I cared for. And she had been in recovery for a long time, had been doing really well. She was still referred to Child Protective Services just because of her history of use, and she was in medication-assisted treatment. So I just wanted you to reflect on that story for a moment. First of all, how do you think she's feeling? She, like I said, had been in treatment for a long time, had a really long labor and birth, and was exhausted and by herself in her room. So what could have been done differently to build trust and eliminate bias and mitigate fear? And you can just hear that in her voice. You know, this was like years later sharing her story, that she still was angry, frustrated, sad, right? Felt probably abandoned. If this was a mother with hypertension or postpartum hemorrhage or uncontrolled diabetes or any other health diagnosis, would we have left her alone to care for her infant after being exhausted with days of labor? I heard some of the nursing staff say during that time about Jen that she's going to have to prove that she can do it by herself since she's going home by herself. And, is that a reasonable thing for us to expect, you know, of any parent? Does that help a parent to engage when we put up that really rigid barrier that there's an expectation that they have to prove themselves? And I think she has a good point. Are all mothers who are exhausted, you know, at risk for dropping their infants? And how do we actually care for everyone in an equitable, non-discriminatory way? So, yeah, some things to reflect on there. What are our engagement facilitators? So we know now fear is a big barrier, discrimination, bias, right? What can we do to facilitate engagement? I'm actually going to skip this just because we're running out of time and share another story with you.
Some sort of substance from the age of 13 until 36.
That's not the beginning. Sorry about that. Let me start that one over.
I knew I needed some Megan, and I'm here today to share a little bit about my birth story with my son, Dylan. In 2019, when I found out I was pregnant with Dylan, I was at the lowest point in my addiction I had ever been. I had been using some sort of substance from the age of 13 until 36 years old. I knew I needed some serious help to get and stay into recovery. So I went to an inpatient treatment center in Windham, Maine, and that's where I stayed until it was time for Dylan to be born. From the moment we showed up at Maine Medical Center, we were treated with the most love and kindness I've ever received in a healthcare facility ever. Dylan was born 7 weeks early, so we spent 3 weeks at the hospital, and that's where, you know, my life changed. The nurses treated me with the most love and kindness. They were constantly building up my confidence from non-existent to when I left there, I knew I was doing a good job. I knew I was going to be able to take care of my son to the best of my ability. It's also helped restore my faith in the healthcare system. I was treated with respect, so I felt very comfortable taking the advice that I was given, not only for my son, but for myself. I took the medical advice that was given to me by my son's pediatrician, and I joined a Moms in Recovery program in 2019, and I'm still part of that program today. You know, the counseling and everything that I so desperately needed, I was able to receive. And if I didn't trust the healthcare system, I would have never felt comfortable going and talking about, you know, the many, many years I spent in active addiction and what led me to that. It also changed how I thought about myself as a mother. By continuously doing the next right thing, I just started to be able to listen to my gut instincts again and know, you know, I'm his mom. I know what's best. Yes, I am going to take medical advice, but I also know my son. And having the medical community also listen to me and value my opinion was the best thing that anybody could have ever done for my son and myself. So thank you for your time.
So some of you may recognize Megan. She was cared for in Maine. She actually didn't have a report made to Child Protective Services during her time there, and said that that was really, you know, an essential piece of building trust with her healthcare providers. And she was able to be in the hospital for quite a few weeks. So obviously the nurses were able to see that she was doing well and keep positively reinforcing that. And we know not every mother has that opportunity. So what helped Megan that you can use in your practice or setting? Just make a note of that for yourself. And this study by Bennett shows us, you know, in addition to Megan's story, what helps with patient engagement. So it's having people encourage you, building trust, self-management support, and shared decision-making. Technology is another key piece. So sometimes, you know, text to encourage people, reminders, obviously using Zoom, as we heard about at the beginning, like there's ways that Maine is really making sure that people have access to that. You know, telehealth, right? And then provider communication was also a part of this study where they identified that when providers, healthcare professionals are getting education like we're doing today about trauma-informed care or engagement, then families are more engaged. There's also the health system level of engagement. So that's kind of that direct patient care that Megan was talking about and Jen. But health system level engagement is when families are participating in QI projects, committees. And then community engagement is when they're participating in, say, like research, you know, across the whole spectrum of care. So this is a short clip about that kind of engagement. You may be familiar with the researchers here, especially Daisy Goodman, who was in Maine for a while.
And I know from my perspective, it was a way of feeling like I had control over something that affected me and feeling like I was being able to help something that personally affected me and will affect other people like me. And, you know, I think a lot of people, they get in a situation where they're not happy with things and they don't know what to do. It's a good way of working through that.
To Sarah, when like the project was.
So this is a great video. I'll make sure you guys have the whole bit, but for the sake of time, I'm going to move on to our next slide.
Like all
if I can, it doesn't want to
stigma that
it wants me to keep playing it. So yeah, you guys will have the link to that as well. We'll make sure I'll put it in the chat actually. And doesn't want to let me get back to my little slide. So
into something good.
Oh. So any questions right now as I finish up with just providing some, is there anything in the chat that I can answer? Lorena, while I'm just getting.
So if you look in the Q&A, I see there's some questions and conversations about substance use, whether or not it equals child abuse and neglect. People are asking how people experiencing chronic abuse can take care of their kids efficiently and to that extent.
Yeah, so for sure, right? People that are experiencing chronic abuse are probably really having a hard time with that. I think one of the things that's important for us to recognize is that what we're often dealing with is people who are experiencing maybe some casual use, right? Or, you know, they're not struggling, but we're reporting anyway. And so are we reporting based on just because there is use or because it's legal or illegal, or, because we always think that any marijuana use is bad, or reporting because there's chronic use that's actually affecting, the child's care. And so teasing that out. So it's not to say that someone with chronic use who's really having a hard time with taking care of their child shouldn't have child protective services involved. They should, right? But does every family? And so sometimes we just get we throw the net so wide. And again, that's what can affect patient engagement. So this, to wrap up, a couple of this study identified that things that help to build trust and patient engagement in the population with substance use disorder is really humanizing care, remembering people are human beings. Not everybody's the same, right? Demonstrating addiction expertise, knowing when, okay, this is really a struggle. This is something that's not really affecting the person's behavior, ability to be able to care for their child. Reliability, and then granting agency. So again, asking the person, like, is this affecting, your ability to be able to care for your child? And when it does, what are you able to do to keep your child safe? So we can improve patient engagement by providing trauma-informed care, assuring that we're following updated protocols, respecting families' autonomy, not taking things personally, and really tapping into love. It doesn't mean we're not going to make decisions to help families be safe, but how can we do it from a way that's in a way that's compassionate? Bunch of resources for you here, including some webinars on trauma-informed care that I made through the Maine Medical Association and Center for Quality Improvement, and some updated protocols that I think are really worth looking at to, again, encourage you to keep moving in the engagement area, especially for families that are struggling. The Academy of Breastfeeding Medicine specifically looks at these substances and makes suggestions around for breastfeeding what makes sense for substances. So here, I just kind of have these 3 substances not named so we can kind of try and guess. This last slide here shows that when we look at cigarettes, alcohol, and cannabis, how are we actually making decisions about people's healthcare and what we recommend and caring for their babies? And what are we doing that's, again, habitual? What are we doing that's really based on the evidence? So it's important that we look at that when we're caring for families. Obviously, legalization is continuing to make things more complex, right? And so we know for sure that cigarettes and alcohol are really have bad outcomes, right, when people use them in pregnancy. And cannabis, we're finding out more and more, does have some poor outcomes as well. But a lot of the evidence isn't nearly as strong, and we're treating it oftentimes in a way that's much more punitive and again, with criminalization and with fear. So you can, you'll have all these slides too to review. Sorry, I'm running out of time, but the Academy of Breastfeeding Medicine essentially recommends that we use a shared decision-making model, just like we use with smoking and alcohol when it comes to breastfeeding. And to wrap up, just making sure that we are using our compassionate communication, our motivational interviewing, and when we're trying to engage families, especially when they're struggling with substance use, with fear, with stigmatization, that we open ourselves to being able to help them to trust us. So how can we make the needed changes in healthcare and social service institutions to reduce fear and trauma and increase access, engagement, and healing? I think we can go back to that word cloud that we started with. So I'll take, some questions. And actually, we probably have to wrap up. I didn't look at the time. If parents are spending much of their income buying substances, how can they be able to financially cover childcare related expenses? Yeah, it absolutely can impact that, right? And so it's not to say that these things aren't impactful, but really teasing it out for all families at the individual level. How can parents experience chronic abuse? Okay, we did that one, yeah.
Well, excellent. I see that it is 9:45 and it is time for our first break. I really appreciate all the information and the discussion it is generating. Thank you so much.
Okay, I want to welcome everybody back from the break. My name is Megan Scott. I am the Substance Use Prevention Program Manager at Maine CDC, and it is my pleasure to introduce Dr. Christie Petrenko. So Dr. Petrenko is a clinical psychologist and researcher who has been working with people with fetal alcohol spectrum disorder since 2003. She completed her graduate training with Edward Riley and Sarah Matson in San Diego, California, and is currently a faculty member at Mount Hope Family Center, University of Rochester in New York. Her research focuses on developing and evaluating interventions for people with FASD, including the use of mobile health technology to increase access to care. She has experience training teams of providers, both regionally and internationally, in FASD diagnosis. Dr. Petrenko also runs a multidisciplinary FASD clinic, providing diagnostic, intervention, and family support services in Rochester, New York. So thank you so much for joining us, Dr. Petrenko. Look forward to hearing your presentation.
Thank you, Megan. Right, so I think I have all my AVs set up, and I'm just really excited to share this information with you today. And unfortunately, we couldn't be in person, but it looks like there's quite a lot of you out there listening in. So I'm going to be speaking about a program specifically called Families Moving Forward, but more to that, understanding why knowing about FASD makes a difference. So in this presentation, I'm going to start with a brief overview of FASD. From my experience, most people don't have the opportunity to really learn about FASD in their training and community programs. So I'm going to make sure we all have a little bit of basic knowledge as we move forward. I'll also speak to the value of an FASD diagnosis. I'll introduce you all to the concepts of FASD-informed care. And then I'll share about the development and evaluation of the Families Moving Forward program and share some additional areas where you could seek out additional training or access to this program. And I'll share just a little bit about the continuum of care that our team is working to develop. So if you have heard anything about fetal alcohol spectrum disorders, you've most likely heard about fetal alcohol syndrome, but that is just really the tip of the iceberg, the condition on the spectrum that has some visible physical characteristics, meaning growth delays and some subtle facial features. But I want to emphasize that this is really a spectrum condition and that the vast majority of people don't have any physical characteristics that would indicate they have this condition to people who aren't familiar with their diagnosis. And it's on a spectrum. It can be isolated or mild effects, or on the most severe end, incompatible with life, including sudden infant death syndrome or severe effects. One of the details that's most surprising to people is how common FASD is. So FASD is one of the most prevalent developmental disabilities in the world. In the US, studies have estimated about 1 to 5% of the general population has this condition. And so if you think about it, that's about 1 in 20, so one child out of every classroom. And, for many of us who are working with special populations such as child welfare or mental health settings, these rates are even higher, estimated on a conservative end, about 6 to 17%, but likely even higher than that. Now, unfortunately, even though it's so common, it's frequently missed or undiagnosed or misdiagnosed. So as many as 80 to 90% of people with FASD never get a diagnosis in their lifetime. But there are some common conditions that either can co-occur or are misinterpreted for this condition. So most people with FASD have difficulties with attention and impulsivity, given the parts of the brain that are most sensitive to alcohol. So that's a common diagnosis. Often people have anxiety, if they have an unrecognized disability and are really trying their best, but people think they're not. That can be really confusing and stressful. Many people with FASD often get diagnosis of oppositional defiant disorder, but their oppositional behavior is typically only when people ask them to do things they don't have the ability to do. There's a common referral question about autism for people with FASD. Although most people with FASD don't actually meet the criteria for this diagnosis when you really look carefully at their symptoms. Many people with FASD experience early childhood and also adult trauma, and so they may meet criteria for post-traumatic stress or other disorders similar to that. Similarly, additional mental health problems and other depression, anxiety disorders, substance use are often can co-occur at higher rates in the general population, likely because many people with FASD aren't getting recognized in the services that they need, and so they have difficulty coping. And many of these diagnoses could be prevented or reduced with appropriate early interventions. Difficulties with behavior regulation are also common, so getting diagnoses like disruptive mood disorder or conduct disorder can happen. I think they're overdiagnosed if you really understand what the behavior is and why people are struggling. And then really interestingly, recently, there's been a lot of research, much of it spearheaded by self-advocates who have FASD, who are recognizing just the really high rates of physical health conditions that people with FASD have. So we often think of it as a neurodevelopmental disorder and think of it as brain-based, but alcohol affects all body systems. And so we see really high rates of things like eye issues, heart issues are higher, all kinds of GI and other symptoms. So we're really starting to turn our research to understanding how alcohol affects the whole body. So that's something to really pay attention to. So I've shared with you how few people actually get recognized. And why is this? Why is there so much inequity for FASD? Well, first of all, is it's not included in most provider education. And as a result, providers, teachers, folks aren't asking about prenatal alcohol exposure. And then furthermore, there are very few providers who can diagnose FASD. For example, in the state of New York, we have 2 individual providers in New York City, and then here at University of Rochester, we serve pretty much the rest of upstate, which for those of you not in New York, that's pretty much the whole, most territory. So people don't have options. People aren't considering it. And part of that reason is due to stigma, that there's a lot of stigma about substance use disorders in general, but also and furthermore about prenatal alcohol exposure. So I want to share with you how an FASD diagnosis can help, because this is a question I get a lot about, given the stigma, providers are hesitant. They want to know, is this going to actually benefit my client or patient? So here are some of the benefits of an FASD diagnosis. So first, it can provide an understanding for symptoms that can be really confusing. When we have a person who has, pretty average IQ, but is really struggling with problem solving and repeating mistakes and memory and things like that, knowing that there may be a reason, such as fetal alcohol spectrum disorders, that can explain a lot of those symptoms, it can really help. There's also, it can help guide children and families to get the right treatment and to change the way they think about their child's behavior or their adult loved one's behavior. And it also creates an opportunity for people to connect with others in the FASD community, which can be a source of really specialized support. Next, I want to share a video of a young man named Morgan, video was filmed when he was 19, who shares from his living experience what a diagnosis means for him. And
I had no clue that I was struggling because parts of my brain didn't develop. I was struggling because my body didn't develop right. So I simply felt stupid. But the more I read, the more I realized I wasn't stupid. The more I read, the more I understood why I did or didn't think in certain ways, why I did or didn't understand certain subjects. And that was huge. It was like 1,000 pounds was lifted off my shoulders. I can't tell you how many times people said to me, well, I don't want to label my child. We don't want to have a diagnosis because that's just going to be saying that they have a problem. Well, denial doesn't help, but acceptance and knowing that you have a disability There's no
Oh, sorry about the internet connection. We have gnarly weather here too. But hopefully you got the gist, and I'm happy to share links to these videos later if people didn't get to get a clear view of it. So I also, as a researcher, put my researcher hat on and share with you what some of the research says about diagnosis. So getting an FASD diagnosis, especially before age 6, but at any time can be helpful, can reduce school disruptions, placement breakdowns, confinement in patient mental health or justice system, as well as alcohol and substance use problems. So this is, I think both from what families experience, individuals, as well as the research shares, can really be quite beneficial for people. So one of the first steps for providers and others is to ask the question, to have conversations with people, to know whether there was prenatal alcohol exposure. It's very common, and there are many reasons why prenatal exposure happens. And to reduce stigma, we really need to be asking these questions routinely to everyone. When we ask about prenatal exposure, we really consider the source of the information. Just because there was a positive toxicology screen for another substance does not mean there was prenatal exposure to alcohol. So we want to really understand in that pregnancy what may have occurred. And so we can ask the pregnant person or the parents, other loved ones who may have been around during the time of pregnancy, and really do so in a non-judgmental, supportive way, recognizing that alcohol exposure happens to many people. There are a lot of unplanned pregnancies. There are people who have substance use disorder who aren't getting the appropriate treatment, and there are many other reasons why it happens. And one of the best ways of asking to reduce stigma and create an opportunity for people to feel comfortable talking about prenatal exposure is to ask prior to pregnancy recognition, knowing that that exposure can happen before people realize they're pregnant. I also want to highlight, especially for folks who are in the mental health system, that there is a way to do FASD diagnosis through the DSM-5. And it's specifically listed under 315.8, where it says other specified neurodevelopmental disorder, and what we call NDPAE is specifically listed under that. And there are additional criteria in the rear section of the book. So while FASD is typically or historically been diagnosed predominantly by physicians in medical settings, there are also ways for mental health providers to do so as well to increase access. Now, fortunately in Maine, you've had some people who have really sought out training through some collaboratives and have the ability to diagnose FASD, and I have some resources to help find those folks. But others can also learn how to do this to increase access. Okay, so let's say we have a diagnosis. Now what? So unfortunately, access to FASD interventions is pretty limited in the community still. It's an area that we're really thinking hard about and trying to find creative solutions. But that doesn't mean that you can't do anything about it. One of my dear colleagues, Heather Carmichael Olson, that you see here, has really dedicated her career to figuring out what are some of these essential elements of FASD informed care. And recently she published a book chapter that I can share with the link for people if they would like, that really summarizes the wisdom from research, from clinical practice, from families that really share what helps. And many of these things you may already be doing or could be doing without changing your practice that much. There's always more we can do, but there are some things you can start on. So the first thing is reducing risks and promoting protections. Many of these families experience co-occurring risk factors that we can support and address. We also importantly need to find and build and use strengths of individuals. So much of focus on FASD is deficit focused, and we really need to pay attention to what's important to them, what they see as critical to their quality of life, and really nurture those. We also want to act as early as we can. We know that early intervention is helpful, but really acting at any time is helpful. There are people who get diagnosed in adulthood. And so at any point that they can identify what's going on and add understanding can be helpful. Offering developmentally appropriate treatment. We know that many people with FASD function at a different developmental age than their chronological age. So we are thinking about what skills we are addressing and what things are important to them at different life stages. There's a concept called reframing and accommodation that I'm going to talk about next in another slide, but it really is understanding that what we see behaviorally may have underlying neurodevelopmental reasons, or sort of thinking about brain-based functioning, that can really give us new insights and ideas of how to support the person. So I'll talk more about that in a minute. We also can target individual level impairments and think about what each person needs, because this is a spectrum and it can look different for every person. Common areas of difficulty include self-regulation, executive functioning. Things like memory and social skills as well are really common. Sensory processing. There are many things that we can do as well to help support that. We often need to be thinking about relationship-based and trauma-informed care for people with FASD. Thinking about context is really important. And there are things, such as accommodations that we can do to adapt the environment to better meet the person's strengths and areas of difficulty. And importantly, we need to help sustain hope. There are many barriers when we think about FASD, and it can be really isolating for families. And so we need to help sustain their hope and help them see the realistic strengths and possibilities for them and their family. And we also need to sustain that for ourselves, that the things that we're doing can be helpful. More broadly, across all these areas, we need to really be paying attention to stigma and how we can help reduce stat and support people. Thinking about collaborative partnerships. FASD doesn't just happen in one silo of care. We often need to collaborate. And then really thinking about community, being led by the community to create culture-centered practices. So I encourage folks, if you're interested, to learn more about this. And I'm going to show a video of a young girl named Shade who will help me explain a little bit about reframing and accommodations to give you a little deeper appreciation of some of these key aspects of FASD-informed care. And so Shade, at the time we made this video, was about 8. And she and her aunt have given us permission to share these videos to help others learn about FASD. So you can go ahead, and hopefully this video will play well.
Shade is an 8-year-old girl who lives with her aunt, an uncle, and baby cousin. Having a new baby in the house has been a big adjustment for Shade. Her family has helped her learn what she can and cannot do with a baby. Shade likes to read to her cousin and will try to teach him things. Like many 8-year-olds, Shade enjoys video games, watching TV, riding her scooter, and playing with a neighborhood friend. She also really likes fashion and going shopping with her aunt. Shade is an active girl and does better when she has opportunities to move her body, such as jumping on her trampoline. Her biggest challenge is managing her emotions when she feels overwhelmed. She can have trouble expressing. Thinking and behavior can also be inconsistent from day to day. Routines are very important for Shade. Her family has learned to be very consistent in how they say or do things with Shade. Shade is a very black and white thinker. When things are not predictable and clear, it can be confusing for her. This can lead to meltdowns.
I say get out.
Consistent people and routines help her feel secure and know what is expected from her. Because of some of her life experiences, it can take a while for Shade to trust new people. However, once you have earned her trust, she is very protective and loving towards others.
Why are you doing that?
She also has a strong sense of fairness and does not hesitate to stick up for people when they are being wronged. Shade also has a great sense of humor. Shade's aunt will often use humor with her when something doesn't go as expected, and this can help turn things around.
So next, I'm going to share one key part of FASD informed care that is really understanding the neurodevelopmental strengths and areas of difficulty for a child, and to really emphasize that children with FASD often have uneven profiles. So what you see here is a child profile graph, and this is from the Families Moving Forward program that we'll talk a bit later. This was made for Shade when she was 8. And it shows that, she has some peaks of strength, such as her visual memory, which is in the very average range here. And she also has some areas that are quite challenging for her, such as behavior regulation and other parts of executive functioning. And so it's really helpful for people to know for Shade where her skills lie, because they can, one, leverage her great strengths with visuals, such as you saw on the refrigerator, in that video that her family has used to help remind her of things, but also providing support in areas that are more difficulty for her, and understanding when she has meltdowns, why that might be. So understanding these profiles can make a big difference in the kinds of strategies we use. This next skill that I'm going to share with you is called reframing, and it really builds on the profile graph. And so I'm going to start over on this side. This is showing sort of how our thoughts, feelings, and behavior about child's functioning. This is sort of our typical way of thinking that we see in our communities and our society. And this is really sort of our automatic thoughts for many of us. So when we see misbehavior, we usually think that it's being willful or purposeful. Like, so for example, if I ask Shade to go upstairs and grab her shoes and her backpack and come down by the door, that's really hard for her to remember to do those 3 steps. And so if I'm like, ask her to come down and she doesn't come down, I'd be like, I might start to think that she's disobeying and not listening on purpose. And so if my thought is that way, which for many of us it is, I might use some consequence strategies to help her learn. So I might punish her or scold her for not coming downstairs when I asked her to, and not getting the things that she was supposed to. But we know with many kids with FASD that those strategies don't work very well. And I'll probably feel ineffective as a parent. I'll get frustrated. And over time, I might be less successful at managing behavior. But reframing offers us a new way of thinking about it. So what it does is it gives that neurodevelopmental insight. So I can recognize for Shade that she really can do 1 step at a time successfully, and 3 is too much for her. So with that new knowledge, I can ask her to just do 1 thing at a time. Or if I need her to do more than 1 thing, I could give her a visual checklist to take with her to remind her of what she needs, and give her some prompts if needed. As a result, we both probably feel more confident and successful managing the behavior, and we can move forward. It's not that we want to be careful not to beat ourselves up for having these kind of more automatic thoughts, but it's more of a process of helping shift our thinking more towards this side as we are able. It's a skill and it takes time to build. I'm going to let Shade's aunt, Crystal, hopefully, if our video quality persists, share her experience with reframing and accommodations, and explain it in a way that makes sense to her.
An accommodation is kind of understanding the individual and maybe their triggers, or why their behaviors are the way they are. And you can stop some behaviors if you know what those are, and then you put something in place so that it doesn't happen. For example, Shade will have loud noise. Sometimes is a trigger for her. So if she's in an environment where there's a lot of noise, I know if I give her headphones or I explain to her what's going to happen, and what environment she's going to be in, it's much easier for her to transition in that environment. Accommodations for me help it so she has less meltdowns. And my understanding, it also helps with the neurological piece of it, where it brings different pathways. So in the future, it'll help her to be able to cope better.
I also want to highlight, as part of these key aspects of FASD informed care, the importance of strengths of people with FASD. And what you see here is a word cloud from some data that we collected a number of years ago from families asking them what are the strengths of their children with FASD. And, surprisingly, this was really hard to get published because people were like, well, it's biased, they have problems. And I was like, that's not the point. Really recognizing that people with FASD have a lot of strengths, and a lot of them really relate to social motivation and connecting with others. And so I just want to emphasize that's something that as providers and family members and other supporters that we need to be really attending to, because it's easy to get lost in the problem sometimes. All right, so I have highlighted what some of these key aspects of FASD informed care are. And now I want to share with you the Families Moving Forward program that really integrates in a systematic way all of these essential elements. And this program was developed by Heather Carmichael Olson in the early 2000s. And it's an evidence-based positive parenting program. It incorporates all those elements of FASD informed care and some specific therapeutic approaches that some of you may know. These include positive behavior support, motivational interviewing. Recognizing what we're asking caregivers to do can be really hard. Not everyone's at the same level of readiness, as well as these other cognitive behavioral techniques that I've shown you a little bit about, like reframing and accommodations. And these are really integrated together. And so Heather and her team, and later my team, have been doing systematic research on this program. The Families Moving Forward program in its initial study was developed within the University of Washington and Seattle Children's, and it was developed to be delivered in families' homes for 90-minute sessions about every other week, and about, around 15 sessions total. So most families about 7 to 9 months to complete the program. And Heather did this trial, and then importantly, after doing it in a very careful, controlled research setting, she tested it again in another community setting with an agency where they implemented it to see how well people in kind of the real world do that. And then later, a number of years later, here at the University of Rochester, we implemented the program as well separately to see if we could replicate the same findings. This is a really important process as we move through research. And so what our research shows is that, first of all, the program is very acceptable, and families and providers have a high level of satisfaction with the program. We also see increases in FASD knowledge, not surprisingly. We see improvements in reframing and specific parenting practices like using accommodations. Parents report feeling more successful and effective. They also use more self-care practices and report that more of their family needs are met. We also, in some studies, see improved child behavior, but ultimately that's a secondary goal. We really are looking for ways to help the family support the child to be more adaptive and functional in their everyday life. And often behavior improves as a result. And if you're interested to learn more, you can go to the Families Moving Forward program website, and I can put that link in the chat later. And you can also see there are ways to get trained in this program. And you can also scan this QR code. And the training to do the Families Moving Forward program is implemented by the Florida Center. And it is a really wonderful program. We've been doing it for years as well here at Rochester, and provides clinicians all the support they need to do FASD informed care. And you may not see it relevant at first to you, but if you start looking and start asking about prenatal exposure, you'll likely find that many Many children and families in your programs and in the community are impacted by FASD, and that this program could be really helpful to them. I want to next briefly talk about an initiative that our team has been doing to try to develop a continuum of care. So we recognize that there are some barriers to getting providers to see the advantages of the Families Moving Forward program and looking for FASD and identifying it and diagnosing it, that's still an area where we have a lot of growth to do. But we know there are many families out there that need information that's evidence-based and accessible. And so we have undertaken a project where we developed a mobile health intervention that's meant to be self-directed by families, that takes many of the key methods and principles and concepts from the Families Moving Forward program and creates an app that families can access. And so we have been doing this work since 2017, and we, again, put my nerdy research hat on, and we have been, we systematically went through a number of phases to increase the likelihood that the app would be acceptable and successful with this population. So we did some focus groups in our initial development after creating a prototype and got input from families and providers. We also did some beta testing with an earlier prototype to make sure the core features were working and acceptable. Then we did a larger feasibility trial to see, does the app work, but also, are we able to recruit enough people to do a larger study, and what are some of the measures and things that would be most useful? And then in 2022, we did a larger efficacy trial to see how well the app works for families. And what we found is that the app, I was a little surprised at how much change it resulted in. I was hopeful as doing this project that people would like it and that it would have some benefit, and some benefit for a lot of people has a big impact. While we know the Families Moving Forward program can have a big impact for families, and it does, it has a bigger impact than the app, but right now, not a lot of families can access it. So if we can do a little bit for a lot of people, that can at least be a good starting place. And so we found the app particularly is helpful in family FASD knowledge. That key skill of reframing seems to be one of its biggest effects. But parents also reported feeling more satisfied in the parenting role and that some of their family needs were being met. And so if you want to learn more about the app, you can also check out our website. It is not currently commercially available, although we're working really hard to get it there. You'd be surprised how complicated licensing and business agreements are, but we're working really hard to get this available to families who need it across the U.S. And then our next step, so I've told you about the Families Moving Forward program, which is done by a therapist one-on-one. It was developed initially for in-home delivery, as I mentioned before, but it's been adapted to be very readily used within a clinic setting using 60-minute sessions, and it works quite well via telehealth as well, which we have had a lot of experience with since COVID. It usually takes all the versions are the same. It's just kind of sliced a little differently, and it takes about 7 to 9 months to do. Therapists, it does take about 40 hours of training to learn how to do it with fidelity and have all the background so that you can successfully implement it. The app is done by caregivers themselves, but what we know is that families need more than that often. Not everyone, but some will need more support than an app can do, but may not be able to access this program. So what we're doing is we're testing and developing right now a program called FMF Connect Pro. This is a provider-assisted version. So we're doing a study where we're going to be recruiting mental health providers to do training on how to screen and diagnose FASD and then support families in using the app. So it's going to be a lot less training to get started, but we're also hopeful that some of the folks who do this program will see the advantages of being able to do the more intensive level and also seeking this out. So we're trying to grow the workforce to be able to offer this continuum of care that the research is showing is really helpful and effective for families. In addition to our work there is some really interesting new innovations that are coming out in this continuum of care as well. So one of my graduate students is just finishing up her dissertation, where she developed a website for teachers that took all of the content from FMF Connect plus some specialized information, really geared well for teachers, and is finishing testing that in a pilot trial. And we're exploring ways to expand and understand how to best implement that in ways that will work for teachers. There's also a colleague of ours at University of Washington that is extending the Families Moving Forward program in the 0 to 3 age range. The standard Families Moving Forward program is a best fit for families raising kids age 3 to 12. And so Bridges really helps think about what supports can be put in place even earlier in that early intervention period. I also have colleagues at Seattle Children's who are exploring some other ways, that especially in short term. So SNACS is a assessment and consultation service that's usually about 4 to 6 sessions. And FAST BEA is a group-based program that takes some of the key elements of FMF in about a 6 session. So these are all things that aren't quite there in prime time yet, but are growing and trying to think of ways to meet people's needs in a variety of settings and different situations. So there's that. And then I want to close this part before I go into a few resources on one of these final elements of FASD informed care and the importance of holding on to hope. So let's hear what Crystal has to say about that.
My hope for Shade is that she is independent in the future and that she can live a somewhat normal life, that she would be successful in whatever she chooses to do. I hold on to hope by looking at the progress she's already made. I think about her when she was younger and she couldn't follow even a 1-step direction, something that kids that age could have already done 3 steps. And now she's able to do 3 or 4 steps without having much of a problem, sometimes needing the reinforcement, sometimes needing cueing, but she's able to do it. Before, she couldn't do it at all. So for me, the hope is that I see progress.
All right, so I'm just going to highlight a few resources here. So first I want to highlight FASD Maine. And if we had been in person, they would have a lovely table that you could go and speak with them. But I encourage you all to reach out. We do have a couple folks who are at FASD Maine who are on today, such as Madonna Mooney, and I think others as well. And they've done a really wonderful job at trying to engage systems and bring awareness to FASD, including there have been a number of providers, medical providers, who have joined the Safest Choice Learning Collaborative and have learned how to diagnose and screen for FASD. And so there are a number of people in your state now who are able to do that. And so I encourage you to reach out and make some of those connections to help your clients and family members. I also want to highlight the FASD United, some of the resources they have. I am a board member of FASD United. It's a national organization that's really bringing people together across the US and internationally as well on FASD. And they have a program that's been really successful. It's been in place, I think, at least for over a year, maybe 2 at this point, where there are people, mostly families, who are really experienced and really understand resources, access, and FASD across the US. And so you can call them 5 days a week or send a message through the website and speak to a real person who can give support and advice and lead you in the direction that you need. And this is not just for families. Providers can reach out, really anyone, they're there to help. We also have a program called Stars for Starla. A lot of kids with FASD don't always get to experience the celebration of their many strengths and talents. And so there's a program that you can nominate people with FASD and recognize specific things that they're good at, or things they've done that you feel like need recognition, and they will get a personalized certificate mailed to them. It's a really neat program that was inspired by a young girl with FASD and her family. Also, the FASD Respect Act is currently in Congress. Actually, it just passed before the holidays, the Senate Help Committee, as part of the Support Act. And so it's being considered and would really help increase statewide planning and access, and thinking about how to take systems and create centers for excellence. So I know FASD Maine has done a wonderful job engaging legislators at your state, and Maine is better represented than most. So you could feel free to reach out and thank those legislators for their co-sponsorship. And if yours is not, reach out and nudge them to do that. And here's my contact information on LinkedIn. Haven't been doing as much Twitter since it became X, but occasionally check that. I can't comment on people's individual situations through email or social media, but if you have a question, I'm happy to try to answer it or direct you to someone who could. And I see that there has been some Q&A and plenty of information in the chat. So it looks like I have about 3 minutes. So I'll check and see if there's anything on here. So I see Brandy has a question about, can adults get a diagnosis or just children? Most diagnostic clinics currently are in centers of pediatrics, which can be a barrier for some systems. We really can diagnose at any age. It just more has to do with the logistics and systems that will allow that. So for example, as a psychologist, I can diagnose from birth until elderly, but my nurse practitioner colleague who's certified in pediatrics is limited to about 21. So depending on if we're doing a mental health or a medical diagnostic system, that can impact what we can do. But really, as long as you can identify a provider who has the skills and competencies to do so, you can really be diagnosed at any age. The earlier, the better for intervention, but getting that diagnosis as an adult can be so helpful as well. Many of the self-advocates I work with really speak to how, just like Morgan did in the video, how much relief and understanding, because if you just feel like you're stupid and a loser and not good at things, like that really impacts you a lot in your life and your self-worth. And so knowing that there's a reason can really then help you figure out how to thrive. I see Lynn also has a question about, can adults enroll in the FMF program? And so FMF, the standard FMF program is really geared for caregivers and for caregivers ages of children 3 to 12. But I will share with you that our team has been also working on an app that's specifically for adults called the My Health Coach program. And we recently did a feasibility trial with that. And later this summer or early fall, we'll be doing a much larger trial to test that app out to see how effective it is. So people found it really acceptable and helped us figure out which aspects were most useful for their lives. So keep an eye out for that. We'll be sharing the word through FASD United and many other spaces when we're ready to engage people in that. So those are the questions that I see. I'll also kind of go through the webinar chat. I see my time is up, and I'll add any comments if people have additional things. So thank you so much for your attention. I hope that presentation was of interest to you.
Good morning, and thank you for joining us today for the Nurture Maine Summit. I have the pleasure and the privilege of introducing Eileen Forlenza, who will speak to us about the importance of engaging families as partners. As a mother to Holly, an adult child with disabilities, as well as her 3 other children, Eileen has effectively represented the family perspective at conferences and public policy discussions at the federal, state, and local level. Eileen is a passionate leader and a change agent on behalf of children and families with a focus on children and youth with special health care needs. Her personal experiences with parenting in the midst of navigating healthcare, education, care coordination, and insurance systems, as well as her ascension as a national family leader, all lend authenticity to her voice when speaking to the importance of family engagement. Eileen has served on a myriad of state and national advisory councils, most notably as the first family leader elected as president of the Association of Maternal and Child Health Programs, AMCHIP. Her advocacy and support of policy development on behalf of children with disabilities resulted in an invitation from President Barack Obama to join him at the White House to mark the 20th anniversary of the Americans with Disabilities Act. On a personal note, Eileen has been a valued mentor and friend to me for many years as I raised my own 2 girls with special health care needs. Please join me in welcoming Eileen Forlenza.
Thank you, Anna. I really appreciate that. So great to be here. I'm going to set my timer so that I stay on track. And I just want to say what a joy this is to be with all of you today. I know that you all are navigating some weather there in Maine today, and I hope you're all safe and warm. I'm going to pull up my presentation here. Give me just a moment. Pull this up. Just a moment, please. All right. Are you all seeing that? I'm not seeing anything on my end. Hold on. Not seeing it yet. Okay. Hold on just a moment. Sorry. All right. Are you all seeing it now?
Just a Zoom screen, Eileen.
You all seeing that now? Yes. Okay. All right. Wonderful. Sorry about that delay. So yeah, I'm going to talk to you today just the family journey. We had some really great presentations earlier today, and this is a perfect lead-in to what my message will be with you today. We talked a little bit already about why we do this work, why we care both professionally and personally. And so I want to keep that in your heart while we're talking about my journey today. My intention of the journey today is to really just bring you along like the pictures of a book and to equate the journey of our family as part of the journey as all of us as professionals and where we want to see the system move in terms of quality, engagement, and of course, better health outcomes for kids and families. So I think, having the pictures, sharing this story will give you an idea of where we can go together and how we can leverage the qualities, the passion, the lived experience, lived expertise of families as we move on. So I want to just start by saying my journey started 34 years ago when my daughter Holly spent the first year pretty much in the NICU. Was not expecting anything. Pregnancy went fine. But like all of us, sometimes life just throws us a curveball, and that's when it started for me. Very early on, we knew that there were challenges with her, and I just want to give a shout out to the early childhood systems that many of you are engaged with. The early childhood system started very early in our life. Holly started engaging through the Part C services, through early intervention. And this is just a clip of us in the newspaper when the programs were integrated and really pulling on the community as a whole, as well as the kiddos who needed a little special attention. So shout out to the early childhood professionals in the room. But what I knew very early on is that, man, we just as a family needed to move through this with resilience. Holly was diagnosed at age 2, finally, with severe, profound mental retardation, is what it was called at the time, severe, significant epilepsy, bilateral hearing loss, and as well as failure to thrive. Holly was diagnosed at age 2. It was literally on my due date for my son, Cody. And within 5 days, Cody was born. And within 5 months, I was a single parent. I had 3 children under 4 years old. In order to access Medicaid services, we were living in poverty. And actually, the 5 months when I started my journey as a single parent, I had to flee to a safe house to protect myself and the children around domestic violence. So I don't say that with easily. I'm sharing all of this to get a sense of what families are going through. And what we know is that the clinical intervention is this much of what predicts a greater outcome. So as a single parent, navigating everything. I mean, I know we've got very many of those indicated today, WIC services, subsidized childcare, all the things. And it was just, I was underprepared, I was undereducated, I was under-resourced, and I'm dealing with a very medically fragile child at the time. But what I did know is through our early intervention services and in our community, just how critical peer supports are. And there was just something inside of me at that time that really wanted to resist a segregated system, or a system that said, you go over that way and we're going to go over this way, but rather knowing that the friendships that Holly was going to establish very early on were going to be vital and just really critical for her as in her own development and for us as a family. You know, life turned out pretty good in general. Holly continues to need care today, but where we really hit the jackpot is that I was able to remarry. My husband, Scott, and I have been married over 30 years now. And we've just made a go of it. And it was part of that resilience, that learning to trust again. And thank you for all the hearts that I'm seeing. Yeah, it was a beautiful love story. I mean, can you imagine? I mean, let's talk about fatherhood engagement. Scott had never been married before, did not have children. And he just said, you know, I just love your kids. And I loved me too, but how amazing. And what can we do to support dads? What can we do to support the brothers and the sisters? And looking at family engagement as the full family is another piece that I want to encourage you today. And one of the things that Scott taught us was, man, let's just have fun. This is intense. Going through all of this is intense, but let's just have fun with it. And so we continued again to build resilience as a family. You'll see Holly on the right-hand side there, just looking very curious about why we're all making silly faces. The little one on the left, Scott and I had our wonderful son, Michael, and he really completed our family. And so as a family of 6, we moved forward really holding on again to resilience factors, navigating the healthcare system. And in this picture, Holly looks pretty typical. She's looking like she's got it going on. But the reality is, this is what she was focusing on every single day. It's what we were dealing with. Her seizure disorder, can I say, kicked our butt. She has drop seizures where she's dropping every, 30, 45 seconds, over 150 seizures a day, which is why in the earlier picture you saw her wearing a helmet. Holly's injuries and compromises really led us to a place of isolation. The protections that she needed with her helmet, needing to sit on small, just segregation. So much of that was just really hard for us, but we knew it's what we had to do. And one of the pieces where I felt the most segregated in the system, as we're talking today around family engagement at a systems level, was in the special education system. We moved in Holly's 4th grade year to a new community, a very typical suburban area. And the very first day of her 4th grade, the short bus pulls up. And I was really perplexed because I didn't request a short bus. Remember, I said, I really believe in integrated systems of care, and not just clinical systems, the entire community. So when the short bus pulled up, I was perplexed. The community we were in before, Holly got to ride the bus with her brothers and sisters. And all I suggested was that, can we at least have a discussion about this so that Holly has an idea of who her community is, who are her neighbors. So what we wanted to do was create the Holly Bus Buddy program. So this is her sister, Emily, who supported all of this effort like siblings tend to do oftentimes. And what I asked was just, can Holly have the right to ride the bus with her brothers and sisters? And what would it take to do that? So with the Bus Buddy program, I created this form and I just explained to the kids what are Holly's needs. We talked about what it would look like to sit next to Holly if you were a bus buddy. And, Emily and Cody and Michael, her brothers and sisters, would be on the bus with her as well. And it took about 18 months to work through all of the negotiations in this new school district that we came into. The risk management, the transportation system is different than the special education transportation system, all the accommodations that we needed to do. But what was really cool is that at the bottom of this form, I asked if anybody was interested, if any of these kids are interested in being a Holly Bus Buddy, just fill it out there at the bottom and bring it back to school the next day. Take it into the nurse's office and let the nurse know that you want to be a part of the Bus Buddy program. And you can imagine all these kids had already seen Holly at school. They were curious about her. They wanted to be a part of things. And that next day, I got a call from the nurses station, probably by noon, the nurses clinic at the elementary school. And she said, Eileen, my inbox is overflowing. Every single kid on that bus signed up to be Holly's Bus Buddy. Every single kid. So what does that tell us about engagement and systems? It caused all of us to reflect, to say, sometimes the system in general really looks at these things through the lenses of fear-based risk management, risk stratification, all of those, when really the community saw this as an opportunity. The parents who I met through this were amazing, indicating that all they've ever wanted was for their child to be raised in an area where they celebrated differences. So really encouraging us to think about the system as a whole. Because you know what? At the end of the day, Holly and I and our entire family, we're still searching for answers. We cannot get these seizures to stop. She's still missing school because she can't get through the day. But on the days that she can get to school, how great that she got to sit next to and make some new friends. So as we continue to search for answers and we move from a community model into the healthcare model, I started really understanding the values of family engagement and started reading deeply. We heard it earlier in the sessions this morning around patient engagement, family engagement. But I want to read this one too. In a growing number of instances where truly stunning levels of improvement have been achieved, leaders of all these organizations often cite that putting patients and families in a position of real power and influence, using their wisdom and experiences to redesign and improve care systems as being the single most powerful transformational change in history. Whew, take that in for a minute. We're talking about quality improvement. We're talking about care coordination, duplicative services. What can we do? Let's talk about how we include family leaders as part of your workforce development plan. We're always talking about increasing the pipeline of diverse workforce, having a diverse workforce. I'm prompting you to think today about thinking of families that you've worked with as part of your workforce development. Another powerful quote: we envision patients as essential and respected partners in their own care, but in the design and execution of all aspects of healthcare. And finally, this is over 10 years ago, folks. We've been working on this for a while in terms of policies that will drive quality improvement by using families with their lived expertise. Patient and family-centered care is an innovative approach to planning, delivery, and evaluation of healthcare that's grounded in mutually beneficial partnership. So that's what I'm going to continue to think about as I continue the storytelling today and turning the pages of this book. Again, moving away not only from community integration and what we fought for as a family, for Holly to have access not just to the bus, to the rec center, to all the other things we fought for, our faith community, our rec centers, our trails that were not accessible, the playgrounds. But today, and where I'm wanting to continue to support evaluation of a healthcare system based in quality, let's talk about health integration that includes families. Because what I realized when I started really kind of engaging in the policy conversations was that, well, I'll be darned, in every other area of my life, if I buy a new pair of shoes, I run through the Taco Bell, shout out to LL Bean, they're always asking me, so how'd it go? What'd you think? What would you rate us on a scale from 1 to 5? And I was like, wow, when do I get to give that feedback to the healthcare system? And that's why this concept of quality improvement of healthcare, we can learn a lot from what we're getting around customer service or customer satisfaction. I don't particularly think that's a direct parallel, but it gives us something to think about. Because in a very quick little snapshot, when I started thinking about if Holly and I are she's the young adult and family at the center of this is just an everyday diagram of what we are navigating on her medical home team. Gynecologist, her oral health, her primary care, her neurologist. And those arrows that you see are basically the function of care coordination and all the other stuff that she's doing that we're involved with home health and her siblings and the rec centers. And I put an X through there because it's not very coordinated. At the end of the day, I'm still doing all her care coordination. And I think for us to have an opportunity to talk about who's coordinating the care coordinators. Every one of these systems have now assigned Holly a care coordinator. And so thinking through from the family perspective, who's coordinating the care coordinators? Did we just create a new position called systems navigator or care coordinator without thinking again around a fully integrated system of care? And when you think about all the systems that I've just mentioned that families are navigating on an everyday basis, we're navigating our IEPs at school through education, our healthcare clinic, the insurance, oh my gosh, whether it's Medicaid or our private insurance or however we're navigating all of that, And then, of course, public health for other needs that we would have. And I will tell you that throughout the day, what I will learn, and what I hope you understand, is that families are the horizontal thread across all these vertical systems. Families are the horizontal thread across vertical systems. So from a quality improvement perspective, it gives you all kinds of opportunities to ask families, again, how's the coordination? What's the referral process? How's it going? Because families have not just lived experience of their own situation, but of how to navigate multiple systems. And so all of the health systems that we're talking about really need a communication mechanism. How are we talking with each other? And families have such valuable information to share. And so how are you harvesting all of the human capital that's in your state? That's my challenge to you to be thinking about as we continue this story. And I just want to share, as I mentioned earlier, we try to keep it light and fun. And I just have to tell you this story. When I don't know, I'm going to say Holly was maybe 8 or 9, and it's middle of summer, and we get in the red minivan with all the kids. So I have like 5 or 6 kids in the van with me. And we decide to run through the McDonald's drive-through before we head to the zoo. And so I get up to the first window, and I ordered the 5 Happy Meals. I just want 5 Happy Meals for my kids, and we're going to carry on. We'll get to the zoo. We'll have a picnic out there, and all will be good. So as soon as I ordered in the first window, then I look in my rearview mirror, and wouldn't you know it, Holly's having a major, major seizure. And she was not wearing her helmet because she was in the car with her seatbelt on. She was safe. So when I got to the second window to pick up the food, I said, I'm sorry. My daughter's having a seizure. I'm going to pull over here. I'm going to go to this little wait area. My daughter's seizures are bad. I'm so sorry. I'll just be right over here. And I was a little frantic because I had all the kids in the car, and I wasn't sure I was going to handle all this. Again, just being a mom, getting through it. And so we get over, I get Holly settled, work it all out. And finally, the woman from the McDonald's comes out, and she brings us our 5 bags of our food. And we get back in the car, and the kids open their bags, and they are not Happy Meals. They are Caesar salads. She thought I was saying, I need Caesars. And so the kids were disappointed. It was a funny moment of recognizing the power of language, the power of the communication. I was trying to tell her my daughter's having seizures. She thought I was saying my daughter wants a Caesar, and it was just funnier than heck. And then again, a pause to say, wow, how important is one word? How important is language? One word. And how kind of her to come out and accommodate us with Caesar salads, which I maybe should have ordered in the first place. But such a time to pause as a family and as a systems thinker that I am, and to say, what could we do differently around language and literacy and dialect and all of the things? So I just share that with you again, just in the effort to keep things light and to keep it real. And so in terms of language and communication, I want to share with you what I've learned from doing this work for 25 years, at least, across the country. I've worked with states, many states, on this topic. And it's really interesting that when I started to keep track of what some of the agency partners, what some of the healthcare partners would say across the country, what do you know? It was basically the same list of why they hesitate to engage families in their QI work. And so I kind of looked at that as, okay, back to the bus buddy story. There's a fear-based way of thinking and an innovative way of thinking. And the partners I found were, when they were stuck, not all of them, but for those who were stuck in a fear-based framework of thinking, this was the list on the left-hand side. Well, families are complainers. All they do is come in and tell us everything that's not working. When really you could say, I'll be darned, families actually have very informed solutions if I just hear them out. We heard that from the kiddo Morgan in the FASD's presentation today, that he just was really, anyway, lots of connections here. We also hear that sometimes agency partners will say, hey, the deficit of that kid is because those parents, they're just not very good parents. So we don't want to engage parents who we don't really think are doing a good job. I'll just leave you with that one. I've also heard from partners that say, well, we can't involve families because the HIPAA regulations and we can't do it. Well, actually, families can sign confidentiality statements like anybody else. I often hear that family-centered care takes too much time when actually the truth is because of adherence and other partnership related, what we heard earlier today around patient engagement, outcomes are actually better. I hear over and over again that families are just not available. They don't have the time. They're too busy. Maybe we need to think about, can you pay them for their time? Maybe the reason they can't come is because they're doing a shift at, McDonald's or wherever they might be working. And so if you could compensate them for the 2 to 3 hours that they're losing on their hourly wage, maybe they could show up. And the worst one I hate, I remember sitting in a room at Children's Hospital and we were talking about this somebody just said, look, Eileen, you're all Pollyanna about this, but the families that we work with, they don't really care. They don't care. And that's not true. And we have to really think as members of the system, which I identify with, we just have to try harder. And then similarly with families, families sometimes kind of get stuck too, and they don't really know how to get out of their own self-talk about, I can't do this. So I had the same list, same concept. And so with families that I've met across the country, sometimes families will say, man, well, my experience doesn't matter. Who wants to listen to me? And really, we need to encourage them to realize that their experiences do matter and they bring a valuable perspective. So I won't go through this. You'll have access to this, but just know that families and agency partners can have these conversations to work through some of these myths. I really want to spend a little bit of time, again, as I traveled the country in the last 25 years, I created what I call the progression. This is a progression of leadership, a progression of engagement, a professional, it's how families get involved. It's this engagement piece. And so first, families get involved in terms of engagement. Their engagement, as we heard earlier, first starts because of their own family. This direct care model. We want to make sure that they are adhering to their care plan, they're getting involved because their family needs care. And then we see families that'll get involved in terms of change, wanting to change something. They get involved to impact their own community. Now, their community could be a geographic community. It could be their country of origin. It could be their faith community. Sometimes it's a diagnosis. Maybe a family just had a diagnosis of sickle cell, and next thing you know, they want to do an awareness fair in their community, or someone wants to do a 5K run. We've seen that. We see families who get a diagnosis, and then next thing you know, they get involved in the community level. And then families will often then go to what I call the outer ring of engagement, where they are working on behalf of systems change for other people that they may never, ever meet. Sometimes families will get involved at the legislative level because they feel like there's a policy change that has to happen on reimbursement or something. And all they know is that this lived experience that they've had gives them some insight. But then you have the decision makers that are attached to this work. Again, legislators, people running advisory councils at a hospital or whatever. And they say, hey, Eileen, we have an advisory board and we need a family who has experience with sickle cell, or we need a family with FASD, or we need a family that has experience with, navigating oncology. And so they want a family to be a part of their advisory. But here's the thing I want you to know. When those people are asking, they are asking for a family on the outer ring. But too many times, we have sent an inner ring family to an outer ring experience, and it is disastrous. So when you think through about how you want to engage families at a systems level, or at your clinic, or at your agency, what level do you want to involve them? Because every single level is important. We do need to hear families and their clinical experience. We do need to hear that. And we also need to have families that represent a community. Again, in Maine, it might be a rural community that covers all kinds of issues related to access to care. But we, the system, because I identify as both, we often, again, have perpetuated this sense that families can't do this work because we have underprepared them. Or what has happened is a family will go to an advisory council. They were not prepared. They didn't know the acronyms. They didn't know this was their strategic planning meeting. And so all they did was tell their story of how they couldn't get access to care. They're on the waiting list for 5 months. And meanwhile, the policymakers are going, oh, great. Well, that's not why we're here. But thanks for your sob story. I mean, I've heard it a million times. So obviously, this is the part I'm really passionate about, because this progression is important. If you look at where we often, as a system, put our funding and our investments, it's mostly in the inner ring. So what are you doing as a state to look at ways to help families choose and decide what level of the progression they want to go to? Because again, the value is at all 3 levels. We need families to articulate their direct care story. We need representatives of the community, and we need families at the outer ring. This is not a race to the outer ring. Not all people go to the outer ring, but we have to prepare for those who want to. My husband, Scott, loves to work with men, dads who have a hard time getting through the systems work as well. So he does a thing that he used to call guys and grills. We'd have guys come over and smoke a cigar and grill burgers and talk football, and then talk about how hard it is or how joyous it is. So again, being mindful of that. And one way to just kind of chat with families too is, before you got all involved in this, before you got that diagnosis, what did you do? Who were you? And oftentimes that's when you hear, oh yeah, I was a marketing person, or I used to run a restaurant, or I worked at the Parks and Rec department. So find the families. I tell you, because I had such an abrupt introduction to the system, I felt like every time I walked into a meeting, as a mom of 3 young children, as a single mom on Medicaid, I felt like I was a paper doll. I felt like I was one-dimensional, and there was no interest in me as a person. And had they asked, they would have known I had a communications background, a marketing background, whatever. And so I've always asked families, like, what's your passion? If you could run a small business, what would you do? And that's really important for you all as you look at how, again, your workforce development needs. And so your responsibility in this conversation as an agency person is to really define what your needs are. When you're talking about family engagement, what level are you talking about? And then put your investments there appropriately. And again, to be mindful of, this is not always an equality thing, it's an equity thing. Not all families need the same things. And I know you all have seen this graphic before, so that in mind as you're working through that. I really wanted to, again, shift your thinking from just servicing families to partnering with families. You need to shift from servicing families to partnering. They are equal partners in decision-making as well as their own health outcomes. And when you're ready to start doing this family engagement, let's look at your own readiness factors. What have you done in the past? Are you ready to share full transparency about budgets and all the other things? And the most important part about your readiness is your budget is your policy statement. Your budget is your policy statement. If you want to talk about family engagement and you don't have any money in the budget for that, it's not going to work. Because families, it's another workforce, it's another group of people that you could serve, that you could say are really valuable as consultants. So there needs to be something in there. And then always, I just want to share this silly picture. This is Emily and Cody trying to sit like Holly. And Holly, that's how she watched TV. She would just prop her little legs up, and I could hold her up with this loosey-goosey body that she had. And I just think this is such a great picture of, let's just be brave. Let's just try to innovate. Let's share. Let's try it. And just, again, remembering that sometimes it looks funny. Sometimes it can be awkward, but we can try together to do things differently. Some other strategies are share your vision across your agencies. The FASD folks, are you sharing that with your early hearing and detection teams? Is your early intervention system talking to your transition team? The 18 to 21-year-old, we know how critical that is. Are you sharing your data, your vision, your strategies? And again, just keep in mind, family-centered care involves the whole family. This is Cody and Michael after a surgery that Holly had. They're involved. They need support too. And as you're talking about family engagement, remember the dads, remember the brothers and sisters. This is a full contact sport, navigating the healthcare system on behalf of kids and families. I think Michael's face there is kind of funny. I also remember when we left the hospital this day that we got like not even out of the parking lot, and Holly threw up all over the place in the car. and the boys are like, oh, great. Oh, this smells terrible. But it's real. Again, once we leave the clinic, the family takes over, and to be mindful of that piece. And that's why I bring this back to what we're doing as a system, what you are doing in Maine to communicate across all these vertical systems, because creating a life for Holly that is meaningful, it requires teamwork, and so it does for you as well. You as systems, as agencies and programs, need to think through about your communication. The kids are playing with Holly here. She has a thing about eyelashes. She's always poking people's eyelashes, so they thought they would get her back. So that's what they're doing, is they're poking her eyelashes. And then I want to just kind of shift again. I'm going to move into the last part of this presentation and then share with you that just like we're doing with our systems change and our systems evolution, so it is with the patients that you've been caring for since they were young. And life goes on. Emily moved on and went to grad school. Cody moved on and is a general contractor. And it's funny because oftentimes people say, why are you showing this picture of your son? The reason I show this one is because Cody's on top of the world. Cody was confident. He knew he could do it. He's got his name, tattooed on his back. And he was like, I'm moving on. Bye, Holly. I love you, and I got to take on the world. And same with brother Michael. He goes off to college. And so what happens to Holly? And so again, thinking about how this equates to your system, how do we continue to bring our partners along? How do we continue this pipeline of family leaders who will change the system? Because when Holly graduated from high school, it did not feel like a celebration to me. It felt like I was going to a funeral. And this is a picture of her at her graduation. She can't wear a hat because she's got all her sensory stuff. She's in the middle of all these people. But I tell you what, this transition time was very difficult. Another part of the system, because we are basically still left behind, navigating, trying to get through her seizures. And so be mindful again of your system, how this family journey informs your systems planning. What are you doing at that transition year? What are we doing to support families through the young adult time? Because what was happening for us at home is after everybody left, Holly literally tore up her bedroom. She literally tore the furniture off its hinges. And one thing I learned as her mom, did I mention Holly's nonverbal? I don't think I mentioned that. So Holly's nonverbal, seizure disorder, still having all this stuff. The only sound Holly makes is laughter. The only sound she makes is laughter. And she's 34 years old now. But what I did learn is that every behavior is a form of communication. And she was struggling. She was lonely, sad, mad, frustrated. So I started taking her with me to conferences, much like this one in person. And a shift happened. There was somebody in the audience who said, "Hey, Eileen, I think your daughter has literacy skills. And if you'll work with me, and the two things you have to be able to do is presume competence, and you have to trust me." And at this conference, I met this expert from San Diego, and we were at a conference in Colorado. And sure enough, within a few months, she came back to Colorado, this specialist did, worked with Holly, and Holly's literacy skills were uncovered when she was 22 years old. Game changer, absolute game changer. Never gave up. We kept working. It's called supportive communication. It's typing on one finger at a time. All of this, again, symbolic to the system. Sometimes we never see the outcomes of our work because it takes so many years. I was blown away. It's a whole nother story. We'll save that for another day. But I wanted to share with you, again, the unexpected. This picture of this young woman was a care provider for Holly at a summer camp. And she believed in Holly. And we call her the Anne Sullivan if Holly is a Helen Keller. And she worked with Holly. She's not trained. She was in high school when we met her. And she found a connection with Holly. And we've come to call these peers the bus buddies. This person symbolized exactly what we were trying to do when we wanted the integrated buses. And that people that are exposed to people with differences are no longer afraid of them. They're curious. They want to support. And so Ashley it just came out of the blue and really worked with Holly and unlocked her on a day-to-day basis. And so it took a long time, just as I'm saying too about the systems work. And the very first sentence, it took probably a year for Holly to type out a word. And then when she finally typed out a sentence, this is the sentence that she typed. No more grape jelly. Do I need to tell you what we are giving her seizure medication in every single day for 22 years? The reason I share this with you is that as a parent, and again, as a partner in this system, we often know what people need, but we don't take time to ask what they want. And that's why that was so powerful to me as a mom. It was the first time I really understood what Holly wanted versus what she needed. And it took me to my knees. That the one sentence that she could type after being locked in for 23 years was, "Hey, I need something else with my seizure meds." And so here's a message that Holly has typed for you all today. So when Holly went to, again, after finally being able to put words together to form a sentence, and then a sentence could form a paragraph, of all the things she had been through, this is what she said: "I want a platform to teach about love." So she went on to, I asked her, "Well, what do you want to do?" And she said, "I want to write a song, and the song will be called God Will Sing You Home." She wrote a book called Just Because I Can't Talk Doesn't Mean I Don't Have Anything to Say. And she continues to teach us. She's got a very powerful story. So the song that she wrote was with a bus buddy. Again, not legitimately, but figuratively. This young woman, same age as Holly. I met her at a music festival and knew that she was a songwriter. And I'm like, "Hey, you want to write a song with my nonverbal daughter?" She's like, "Yeah, that'd be cool." And so again, that importance of systems integration, care integration, community integration. Megan Burt, look her up on Spotify or whatever. She's amazing. And she co-wrote the song with Holly. And through all of that, Holly's self-determination was real. This is what the typing would look like in the on her iPad. And I just want to point out, she would say, this was just a conversation. She was like, I love the name of the song. I've been thinking about it a lot. People pleasing others in their life is pleasing to God. Please push Megan to meet up. Loving others through service. Please push Megan to help me. Please, Megan, for a meeting. Please give Megan my phrase, loving others through serving others. And I say, Holly, do you have any more to say? She, yes, let me kick you out. Let me out of your room. Yes. It took a while, but I'm so proud of her, and I'm so proud of you all and what you will be willing to just stick with it. Just stick with it and keep working hard, because it matters. This again, Holly's book, just because I can't talk doesn't mean I don't have anything to say. And some of the excerpts in there, just to want to leave you with Holly's words, not my words. I hated getting told in kindergarten there was no way I would ever become normal. I've been called retarded from the day I was born. It makes me feel worthless. I hate that word. Ugh, I hate that. And then, in a very typical way, I really want to fall in love. She has had a few love interests, and that's another presentation. So this is Holly's siblings now. This is a couple of years old, and Holly wrote, she wanted me to share with you all, as she does with all her audiences. She wanted to share this. You need to know that you are loved. Sometimes people think my life is a struggle. My life is harder than others. Others' lives are harder than mine. I know that in time, people will see how the hard things make you stronger. Don't give up. Learn to trust God. Sometimes he works slow. Nothing is easy for me except love. Love is natural, but learning to trust the love around you is hard. When you don't feel love, you need to love yourself first, and love from others will follow. This is coming from a nonverbal person who can't pull up her own pants, fix her own meal, and is still having hundreds of seizures a day. All of this inspiration and motivation to you, again, symbolic of what we've all been working for, which is to have a system that focuses on whole person care. And the clinical system is part of that, but so are all the other systems that we work with. So I don't have time to share Holly's song with you, but these are the lyrics to her song. And you also have a handout that Lorena will be sharing with you. And then there's an MP3 file, or an MP4, I guess, an audio file of her song. Had we been together as planned back in November, I would have been able to share the song with you live and sing it for you, but that's not going to work today. But I just wanted to thank you again, and know that as you guys go into lunch, you'll be hearing the song. And again, you'll have the lyrics as well. And I just want, again, as you are inspired, as you keep hearing things around, how to do your job better and differently through this conference, just remember, we've all come a long way. We've all come a very long way. And don't give up, because you are part of bridging this gap for families. You are part of the system that makes a difference. And you are bridging the gap for families from knowledge to understanding to confidence and competence. And finally, just know that the MCH populations need you, because the MCH systems to navigate are very challenging. And just thank you so much for your commitment to working with families. And again, from the framework of not necessarily just servicing them, but partnering with families. So thank you. You'll have access to all of what I've shared today, and I appreciate you going through this book with me today and the journey that we've shared. I appreciate it. Any questions that you might have, if you put them in the chat, send them forward. I will respond to every single one, in the next couple of days, because we're out of time now. But if you have any questions, comments, whatever, please know Holly and I are very responsive, and we will answer any questions. No question is off the table, and we'll respond as soon as we can through email once we get all those questions. So thank you very much.
Thank you, Eileen. That was truly inspirational. Such great information and so empowering and motivating. And Holly will be playing your song in just 1 second. She has to share her screen in order to do so. I put the lyrics in the chat, And please, everybody, take a listen and enjoy your lunch break.
Find a smile when you feel alone, overloaded. I'll help you shine even when you can't find a way out. I want you to see your abilities. We've got a song to sing. Raise my voice to the sky, sing my love and on high. Love is pleasing to God, pleasing to God. He will hear your voice too, sing you home with you. Hallelujah, he'll sing you home. I can see we've got all the love we need around. In the air, it's everywhere. Just reach out and grab some. Every hand you hold, and eyes may close, serving someone in need. Raise your voice to the sky, sing your love and on high. Love is pleasing to God, pleasing to God. He will hear your voice too, sing you home with you. Hallelujah, he'll sing you home. Show somebody kindness, show someone you care. Let somebody know you are there. And raise our voice to the sky, sing our love and on high. Love is pleasing to God, pleasing to God. He will hear your voice too, sing you home with me. Hallelujah, he'll sing you home. Love is pleasing to God, pleasing to God. He will hear your voice too, sing you home with you. Hallelujah, he'll sing you home. He will hear your voice too, sing you home with you. Hallelujah, God will sing you home.